Well, we had the first barrier question come up already, so I'm going to go back to what I said the panel, but we're going to make it a little easier for the panel by setting the table right now. What do you do if you only have a part-time pharmacist? How do you set up an antibiotic stewardship program? How do you, anybody done it? You have, all right. So tell us how you did it.
So our pharmacist is remote, and they see everything. There's 2 or 3 that work together, and they look at all of our orders, be it 12 hours, 24 hours, depends on who's on. And then they call back and address what issues we have. They also helped us with our stewardship program, and they will call the doctor if the nurse doesn't want to. So, but they do it remotely. Every now and then for med staff, they'll have a telecommunication video with them, video chat. Sometimes they'll be in person at our med staff meeting. So
where do they live and work?
I don't even know. I don't know where they live. Iola.
Iola where?
Kansas.
Oh, so they're like local guys. Yeah.
But I think there's more than one. I think one lives in Iola and then somebody else lives somewhere else because we do it all remotely.
So we're going to hear in the next hour about telestewardship. This is an example of telestewardship. So the first answer I'd say, if you only think you can do it with the 4 hours of the part-time pharmacist and 0 other pharmacy support, you're right, you can't do it. But so you need, this is leadership and will. And it might mean at the beginning it costs a little bit of money. Okay? Who else has another solution for this?
I do have a pharmacist that we call and talk to in North Carolina.
Okay, but do they monitor your? Okay, okay.
I have a local pharmacist that does that.
All right. So if I order a fluoroquinolone that seems kind of wacky, are you going to call the North Carolina doc, the North Carolina pharmacist? So are there triggers your local pharmacist might see that makes him call?
He tells the nurse, and then the nurse tells the doctor the next morning. But my doctor is real good about looking at the types of antibiotics,
Yeah.
and all his protocols are set up that way. And then if they deviate from that, he wants to know.
When you say your doctor, your
My primary care physician.
okay. So we got an answer in the back too, but I just want to keep going with this for 1 second. So remote pharmacies. Go to Iola, Kansas. Using far remote pharmacies that maybe don't have specific triggers, but when somebody smells something that doesn't seem right, they can contact that person and get another opinion. Yes, you have another solution?
Well, I don't know that I have a solution, but I want to echo something you said. One of the things we found was that if the physicians, providers, the prescription writers do not trust the pharmacists giving the information, I promise you, they will shut down.
Yep.
And so what you'll find in a bigger institution is there's only certain pharmacists that docs call. Katie being one of them. Because once a pharmacist gives a wrong answer,
Yeah.
you're done. So keep that in mind when we talk about MAD-ID, and your pharmacists really have to be educated or confident in their own
I
information.
agree. Katie, what's your number? What's your phone number? Who's Katie? Katie. No. What's your number, Katie? What's your phone number?
Really?
Yeah. Oh, she said that so fast on purpose. She's clearly on a salary. Okay, but over here they said something I really liked that echoes what you just said. The pharmacists are remote, but they come to medical staff meetings. So they're not just creatures of the ionosphere out there. They're not just these fictitious things that nobody even knows if they're, that could be a 4-year-old playing on a computer, right? I mean, who knows? But they come and they show up. Remember what I told you about FaceTime? FaceTime is the way you, whenever you can, and I don't mean the program. I mean in the same physical space, seeing each other is important. Any other suggestions for small hospitals, or any of you in small hospitals that have done this and made it work? Yep, over there. Ladder truck. Okay.
in Ulysses, Kansas, a few years ago, the local pharmacy took over monitoring and helping run the hospital. So they had pharmacists there. They would have the same software, they'd check everything and then go in like once or twice a week to make sure everything was running right there locally.
What a concept. Seamless inpatient to outpatient. Yeah, I mean, that's great. So I think, you know, I think it depends on, I suspect it depends on the capacity of your local pharmacies in these small towns, the age of the pharmacist, the willingness to try new things. But in this technological age, no place is remote. You know, I mean, Navy corpsmen on ships are being walked through how to do appendectomies through video chat live by the naval doctors on shore. Did you know that? I mean, otherwise, what do? Just play taps and send overboard? So, I mean, you know, there's an amazing amount of things that you can do in this world today, and you got to think outside of the physical space of your community. Yes?
Hi, I'm Nikki Presley. I'm from Hill City. One thing that we're a very critical access hospital. Don't get me wrong, pharmacists are very important and they play a very important role. My job is I'm a pharmacy director. So I'm a nurse, I'm an RN, and in most critical access hospitals, we have a nurse who is the pharmacy director. They're playing that role. So as important as all this is, they're the ones that are going to be there probably doing most of the work. And then your remote pharmacist who comes in whenever, they're going to work with them. But this job is going to be on a pharmacy nurse.
This is why we have meetings like this. I mean, is that the God's honest truth or what?
Mm-hmm.
Yeah. And then who gets to go talk to the doctor? What's your name, Nikki?
Nikki.
I see Nikki coming. I'm changing my orders already without us even talking. No, really. I mean, this is it. We talked about I said it's a community watch program, right? That's what it is. And so what we need to do is to empower the people that are in positions to make a difference. And they don't need to be pharmacists. They don't need to be pharmacists. But people have to learn about this, care about this. You might want to take that MAD ID. Up your game? Yeah. Okay, that's great. So way back to where we started. Does this help you with what to do? Any some ideas to what to do? Yeah.
Yes.
Okay, good. That's the whole roll. All right. I have another barrier I want to talk about. Then I'll ask you for your barriers. Blood cultures. I said, what day do we stop doing those? I don't know. What are the barriers? What do you think the barriers are for physicians in getting blood cultures? Time it takes to get it done. And in fact, as I told you, if you look at the Surviving Sepsis campaign and the critical care medicine, they specifically say, do not delay antibiotics for blood cultures. And that's a sad statement. It's an appropriate statement, but it's sad because it means we're not getting the blood cultures fast enough. So I was asked by someone here about what the role of the lab is in a lot of this. And there are many roles we can talk about. But one is to facilitate the drawing of blood cultures. Now, in most of your hospital, I'm guessing the nurse in ED does it, right? Sorry? I mean, big hospitals, often it's the lab. But lab in yours, okay. Where's the lab come from? How long does it take? I'm in the ED, I got a patient who's either septic or I got a patient with pneumonia or some abdominal thing. I'm worried about them. I'm getting ready to start antibiotics. How long until I can get blood cultures drawn? Yeah, 15. Am I going to wait? No, I'm not going to wait. In fact, the experts say don't wait. So we got to figure out how to do this faster. Okay?
Well, what about not necessarily the amount of time it takes to get the blood cultures, but get the result?
Oh no, we're coming to that. That's part B.
My guys draw a rainbow, a rainbow, and then you draw extra. I guess you could. I could put on protocol for
I don't know. I mean, I just think that what you do is you have to make it easy. In fact, if you hear any one of our 6 or 7 members of the Cynosure team, we're going to beat into you, make it easy to do the right thing. Make it easy for people to do the desired practice. So, what do we need to do? So now we got this outline. It's 15 minutes and I'm not going to wait. What do we need to do? I only exercise when I write on plans, so I take advantage of it.
Our nurses draw the blood cultures for the lab when they start the IV.
Okay? And is there a lab director in here? What's your worry about every Tom, Dick, and Harry, Susie, and Nancy drawing blood cultures? Yeah. Yeah. Okay.
Then the issue is the provider has to decide, is
Yeah.
it contaminated or is it not?
Let me just tell you something. I'd rather have that worry than no blood cultures at all. Let me wander through that maze rather than having no blood cultures. That gives me nothing. Now, no disclosures. No disclosures regarding this. There's a company out on the market now, and they're going to get copied quickly by some way they'll figure out it's not a trademark. That uses an IV's blood culture drawing device. It is dual chambered. Automatically, after the first half cc of blood is brought into the chamber, it switches and the rest of the blood goes into the second chamber, which is the blood culture chamber. So they're isolating the skin isolates in that first half cc. I don't remember the name of it, look it up. Talk to your people. I'm not selling it, I don't make any money off it. But it's one of those Homer Simpsons, you know? Why didn't we think of this? And they have shown that with anybody drawing it, nurses, trained lab techs, or anything, they get contaminants down to 1% of draws. So look into it. I said I wish I had the name. One of my colleagues has the name, but it is. If you can't find the name, email Michelle, and we'll figure it out with my team. But again, I'm not trying to sell this, but it's selling itself because it's brilliant. So we have to figure out how to do that. So I think you just have to have point-of-care blood culture capacity. And I'm not saying you have to use this product, but the people doing it need to be proficient at it. Otherwise, and like I said, I'll take the contaminants over waiting. I mean, it depends on how sick the patient is, you know. But we do know that mortality in sepsis goes up 7% for every hour that the blood cultures are delayed. So maybe it's only 2% for 15 minutes. Is that the same?
I was just going to say, we've got our paramedics and EMTs, when they recognize in the field that it's possible sepsis, they'll draw a set and get it going, then they can get the fluids going.
How about that? And then there's also, you can also do, we're not a sepsis doctor, they can also do QSOFA in the field too. Okay, any other tips and tricks on getting past this first barrier? All right, let's go to part B.
There's one back here. I was going to make a suggestion.
Please, wait.
This is in regards if you use a remote pharmacist or if you don't have a pharmacist. Sometimes the pharmacist will help you get educated like route changes, how to adjust medications for renal failure and so forth. So that's just another option too, is to call a pharmacy and see if they can help you with some of that information.
Yeah, and I would just add to that if you're in a critical access hospital and you have a typical tertiary referral pattern, and you're not calling every hour on the hour, you can probably create a relationship to allow you to get to an ID doc or something to at least answer the question for you now and then. If it's going to be more than that, then maybe some money has to change hands. But you all have tertiary referral patterns, so you can use them. You can use them as well. Okay, part B. Got the blood culture, everybody's happy, and now it's 6 weeks from now. No, I'm kidding. Now we're at 48 hours and there's no results. In fact, at 48 hours, it's still in our fridge. So what do we do? How do we fix this? Anybody have this problem? Slow turnaround time on blood cultures? Yep, over here. You have it? You sat with your back to me, hoping that I would not see you. But then I moved around.
So our lab,
You're on.
we can do a draw on Saturday mornings even, but if the people that come through to take our blood cultures up to North Platte to get processed, if it's not in before 11:30, I think it is, in the morning, then it's got to sit till Monday morning at 11:30. Anything that's drawn after that time each day sits until the next day before it can get taken anywhere.
Time to get your Uber app. Wait. I know that. I knew that. Sorry, Dorothy, we are in Kansas. Somebody other hands over here struggles with turnaround time on labs? Now all your hands are down. There's several hands went on one table. Yeah. But this is an important thing that she brought up. And granted, I worked in a metropolitan area, but on more than one occasion, back in the day when I was crazy enough to work the ER a lot, we sent specimens by taxis to the reference labs, because we weren't going to wait until their next pickup time. So that maybe not be an option, but I do think it's important to at least think about these things and not accept them as etched in stone. It must be this way. Get creative, you know? Get creative and start thinking about how you might be able to. That's a problem. So you put a sign in front of the emergency room that says, if you're sick and you might need bloods drawn, please wait till Monday morning. The colony count will be higher. Yeah, these are real challenges. I mean, they're real challenges. And any other ideas on how to help her out with that? Okay. What did you say? What did you say? DNA testing. DNA testing. Well, see, I always have fun with this blood culture thing because it's been a crusade. I taught residents, and it's been a crusade. I mean, you know, my residents literally died on the block. They didn't get the blood cultures either. That was one of the mortal sins of being a resident, was not getting blood cultures. But this day is going to come to an end. This is a transitional conversation. Why is it? Can you talk about this? Well, you start, and then we got folks in the room who finish with you. DNA testing.
So there's certain products out there that you can have in your lab that the one that we were presented with can do cerebral spinal fluid, blood, sputum. I can't remember the other one. But it takes 15 minutes to tell us if it's a fungal infection, if it's a viral infection, if it's a bacterial infection. Then the susceptibilities will take a little longer, but not quite as long because we already know the bug.
Is it like
so we can do
4 hours or something?
Yeah, one of them is 15 minutes that you can get if it's a bacteria or a viral. So you can already go to the direct antibiotic instead of a broad.
And that really helps in the winter when you have an influenza epidemic.
We haven't got it yet. We're looking.
Okay, all right. So here we go. These are tests that I think are going to obviate the need for blood cultures. Who uses PCR for C. diff in your lab?
We do.
Yeah. What's PCR? It's polymerase chain reaction. It is DNA. You just amplify the DNA, and then you can read the DNA. You can read the actual molecules of the DNA, and you can. Those molecules are embedded. Why do we use it for C. diff? Are we looking for all C. diff? No, we're looking for toxigenic C. diff. And if you're going to get toxigenic C. diff, you have a string in your DNA that directs the toxin manufacturing. And if you're not toxigenic, that string's not there. And so these tests rapidly identify the genome of the C. diff and determine that it is C. diff and whether it's got the toxigenic genes in it. Go ahead.
Yeah, so PCR testing has its ups and its downs, okay? You have to have a lab that's equipped and properly equipped to do PCR. So a lot of times it's the regional lab that you send the specimen to that actually have the capability. There's the respiratory, which is nasopharyngeal. You have the spinal fluid, the blood, PCR, and the GI panel. The downside is susceptibility testing, because it doesn't do susceptibility testing. So you still have to grow the organism in order to, get the susceptibility testing. But it is rapid. Mostly it's 90 minutes. Of course, if you have to send your specimen somewhere, then you have that same problem, right? The other problem is the insurance companies. So we in Kansas, and I won't name the insurance company, but you all know it already, will not pay for the GI panel because they've decided it's experimental.
Yeah.
And yet all of the national organizations are saying this is the way to go to get rapid diagnosis so you're not treating those viruses, for example, or you know what your pathogens are. So if any of you have a way to get around this particular company to pay for these panels because they ask you to do the individual tests, which are more expensive.
Right.
Just thought I'd mention.
Yeah, the other thing I would add to what you said is a couple things. For PCR, I don't want to focus on PCR because I'm going to jump to the next level here. The other thing for the PCR is that it doesn't tell you that the C. diff is actually making toxin in this patient. What doesn't tell you it's CDI, or the IPs in the room. And the problem with the GI panel I have is that there's no indication that the patient may have C. diff. It ought to be GI panel minus C. diff, or you're going to get a million false positives. It's going to take you down the Mary Lane. Okay, but the next level of testing uses some similar technology that actually identifies not just the bacteria, but susceptibility patterns that are reading. Because when, I don't know if you know all this, but all the microbes in your body, and particularly your gut, they're ganging up on us all the time. That microbiome, all it takes is one bacteria of any genus and species to develop resistance pattern, and everyone in your gut will develop it too. So E. coli can send it to Klebsiella, and back and forth. They're trading. They're trading their genome, laying there in your colon. How fun is that? So, the bottom line is that whenever a bacteria has susceptibility, develops resistance, it's because it's had a genetic change. It's doing something different. It's either develops something that destroys the antibiotic, or it blocks a receptor, or it does something. And so what's emerging, and there's several companies out there, I don't want to name their names, but what's emerging is the ability in 4 to 6 hours to identify by a blood test the organism and its susceptibility. And that's, I think, where we're going. Would you agree that's where we're going?
We're going there. The problem with the blood is that for our current PCR, Brian is behind me, the bug has to grow in the bottle.
Yeah.
Right? So it's not what you're thinking, like a spinal fluid, for example, again, can track these things, or I should say the respiratory panel goes directly out the nasopharyngeal swab, but you got to grow it. The BACTEC machine or whatever you're going to use is going to be firing off, so you know there's something in the blood culture, and then it tells you what.
Right. So what it's going to do is this is the future. It's going to obviate the need for blood cultures, I think. I think we're going to get there. In a decade and maybe sooner, it will obviate the need for blood cultures. We'll be hammering people about blood cultures. And we're going to get the diagnosis quicker. Even though it has to grow, I'm told that people are getting answers for 6 hours on critically ill ICU patients as to what the ID and sensitivity is.
And it will tell you if it's
And
got
MRSA.
a gene with MRSA.
Picks up MRSA, that. So how powerful is that? Okay, so that's where we're going. Welcome to the new world. We can stop talking about blood cultures. So that was on the list. That's a list of questions that probably already lost. Talking about that. What's new? Oh, anybody using Procalcitonin? Yes. Who's got a hand up here I haven't picked on yet? Hands up. Come on. Hands up. Hands up. Picked on you, didn't I? All right. So how do you use the Procalcitonin? Tell people what it is and why you use it and how you do it.
It's a biomarker for, mostly for sepsis, and so hopefully you're looking to see if it's bacterial. If it's negative, then you're leaning more toward the viral. It should be used really for antibiotic stewardship, and that once you get a positive and you know it is, then it should start coming down at a logarithmic pattern if you're on the right antibiotic. Ours, we're struggling there. We get them on admission, and then they tend to do them daily without really paying attention to the antibiotic, so we're working on that.
Yeah, I think it's an important, it really helps this viral versus bacterial, and it helps you de-escalate your antibiotics. So it's another tool. Boy, we debated this one in the literature for 10 years. I think the jury's back in now. It's useful. Remember, when I started researching this, it was like this, but more and more the evidence seems to be pushing in this direction. So I like it for that it is a quick viral versus bacterial, and it is the de-escalation thing I think is important. If somebody looks at the numbers, it ought to be a crime against nature to order a lab test and not know what it shows when it's resulted. I mean, it's a waste of everybody's time and money and blood. Okay, what else came up during the break? Let's see. Well, let's talk more about the role of the lab. And then I'm going to open it up to you folks. What's the role of the lab? In all this antibiotic, we talked about the role of the nurse. We talked about the role of the pharmacist. We talked about, more or less, the role of the IP, who's a critical member of this team, and I think needs to know as much about antibiotics as anybody else, because he or she is often the driver of this. So IPs, you can up your game. We talked about the prescribers. We talked about leadership. We talked about staffers. And what's the role of the lab in all of this? We hit on a couple of things. Maybe these rapid ID tests. Maybe it's the blood culture promptness. What else can a lab do? Where's a lab?
Mine tracks my organism.
What do we call that? Antibiogram. So, okay, so, you know, I'm gonna segue for 1 second to something else and come back. I was asked in the break, okay, so we collect these days of therapy, these DOTs, what do we do with them? Okay, fair question, because I didn't address it. You track them over time. There's not been a successful antibiotic stewardship program that I've ever heard of that you did not see decreasing days of therapy over time. That's not necessarily your goal. Your goal is the right antibiotics for the right patient at the right time, and sometimes that means escalation, not de-escalation. But normally I would say probably 8 or 9 times out of 10 it turns into de-escalation. So you're using fewer antibiotics for shorter durations. So you should see your days of therapy go down. Back to Tara Ruffner in Soldotna, Alaska, they were focusing a lot on their ICU. They were 60-bed rural hospital. When they showed me that their DOT was actually kind of going down, but it was okay. They've gone down 10 or 20%. Maybe. And then I said, let's segment the data between your 4 beds and your ICU beds. And she was shocked. There had been almost no movement in DOT on their 4 beds. But they had a 57% reduction in their DOT in their ICU. So the sickest patients were getting better antibiotic stewardship by far than they ever had before. So it's an internal benchmark. I don't like benchmarking it to the CDC. And there's an SAAR. There's all these things you can do. But, you know, there's another thing that's probably ingrained as me as a physician. Really, really hard to case mix adjust anything. It's a crapshoot. And so maybe your patients really are sicker than someone else's. Bottom line is that it's a wonderful internal benchmark, one for you to track over time to see what your progress is. But is it truly an outcome measure? If our outcome goal was simply to reduce antibiotic use, then that would be an outcome measure. But if we go back to those goals, is that what our goal was? To reduce it? No, it was to use it better, smarter, more targeted, more pinpointed, which just happens to mean it gets reduced most of the time. So what is the true outcome measure for antibiotic stewardship? Your antibiotic. That's the true outcome measure. The problem is, we get them once a year if we're lucky. You know? So I want you to start heading off towards Nebraska on foot. And in a year, I'll tell you where you are. You know? So that's the challenge. Now, there are big hospitals that can and should do an antibiogram more often. I've worked with some that do it twice a year, and now I'm working with one that's doing it 3 times a year. What's the rate limiting step? There's 2 rate limiting steps to doing an antibiogram. One is will, and the other is enough isolates so you don't get a bunch of asterisks in all your boxes. It says not enough data. So, if you are in a bigger hospital, ask if you can do it. Anybody in a 200-bed hospital or bigger here? Just you guys. Okay. Over here. Ask if you can do an antibiogram more often than every year. Okay? So the true measure of stewardship is like in England. It's to see those cases come down, but it's also to see the resistance patterns change. And there's good studies in the literature with specific hospitals that show that over time, a stewardship program of 3, 4, 5 years, they have seen their sensitivity, their resistance patterns start to reverse. They're seeing their number of resistances to some of the antibiotics do this, and then peak and start coming down again with more and more susceptible isolates as part of their percentage. When we talk about stewardship, at the patient level, the hospital level, and the community level, that's our ultimate outcome, is to treat patients, get the same clinical outcomes, and yet reduce sensitivity. Who caused this whole resistance pattern? We did. The collective giant we. Patients, families, doctors, pharmaceutical companies, pharmacists, nurses, all of us. So it's we who have to then turn this pattern around. We can do it. We absolutely can do it. It's been shown to be done in organizations and in other countries. So that's it. Now, what do you do when you can't even get an antibiogram in your little hospital? What do you do?
I do my own.
You did your own, but did you have enough isolates to get some of the key things?
I had 10 cultures
Okay.
for the month,
Okay.
so I just write down how many of the organisms, go across and mark what antibiotic was used, and then I total it for the month.
Okay.
And then I total it for the
So you're not worried about statistical significance?
I show it to my doctor.
Okay, that's fine. Okay, yeah, I mean, that's data. Okay, we can argue that it's not perfect data, but it's data. And if you got, what's a typical number of isolates in your hospital for a month? Of any source?
5.
So ferrets, anything? 5. Okay. All right, and you do it every month? Do you ever accumulate them over a year and do a cumulative?
I do. I just started.
Okay.
I do a month and then quarter.
And then you can sum up into a year. Yeah. Okay. Yep. Yes, ma'am. Who are you? Where are you from?
I'm Christy Smith from Scott County Hospital, and I presented my docs a year and a half ago with an antibiogram from Quest, which then they promptly asked me to do my own. And so I had to learn how to do that. But we had a great success. We do it yearly because like we had 350 positive urines. We do it most effectively with urines because we have less blood cultures for skin and blood. But I knew that we were prescribing too much Cipro for UTIs, but me telling the docs that that just doesn't work. But that antibiogram told them, and we are prescribing less and more effective antibiotics. The other thing I discovered halfway through was that I felt like our nursing home patients had different bugs than the general population. So this year I am separating out nursing home patients from the general population.
That's terrific. So showing the data to the docs isn't always enough, but it is a start, and you have to do it, and they have to believe it's local. So let's say, does the state of Kansas, the health department do an antibiogram for the state? Some states are starting to do that now. Montana and others. I mean, what's an antibiogram from Johns Hopkins mean in Manhattan, Kansas? Nothing, right? I don't know who's better and who's worse, but it means nothing, okay? So we're looking at that. The other thing we've started to see, the state of Montana is now looking at regional antibiograms. Let's get enough so that we do get enough to make it statistically significant. And then we can do this overlay that you're talking about on top of that and look at what we're doing, even though maybe not enough numbers to make a statistician happy. At least we can see sort of intuitively if there's any variation in that. And so something to think about. Another thing we've seen happen is hospitals that refer to a tertiary care hospital is use their antibiogram. Your patients are coming there and going home. You may be great. They may not be. They may be coming home with resistant bugs they're picking up there. So, use what you can. Be creative. Get 5 critical access hospitals together and pool your data and make an antibiogram. I mean, again, this is will and ideas. The execution's easy once you decide where you're going to go. Will and ideas. The ideas are easy. Form a little community. Form a group. Form a gang. Tackle the world with a gang. Really, I mean, don't sit there at a small hospital and say, Okay, I'm not calling you this, but this is one of my favorite cartoon characters because he evokes so much. Don't be Eeyore. Oh, I guess I just have to sit here and not have an antibiogram. So figure it out. Go get one. Get your friends together. I guarantee a Tigger will take you somewhere that'll get you an antibiogram. So be creative. Be creative. The antibiogram is where you ultimately want to go. And let me tell you, when you can start showing movement of your resistance patterns, reversal of your resistance patterns to your board of directors, you're going to get a Wonder Woman cape. I mean, it's really amazing when you can start showing the impact on the community of these kinds of effort, because now it's not just the hospital, it's the community, right? So, powerful stuff, powerful stuff. All right, I have one more question, and then I'm going to open up to any other barriers you might have, because I'm feeling this is one of them. How do you get your docs to pay attention to this? How do you get physician engagement on antibiotic stewardship? Anybody have any secrets they want to share? Come on. Thank you.
I think doctors are interested in outcomes that affect their patients. So you have to make it where it kind of engages them on a patient level. They like to see that what your efforts are doing are impacting those patients and the care that they get. And also helps them to make their job easier. So that's how I do it. That's what I do.
Anybody want to try to top that or add to it? I mean, as I said at the beginning, it would be nice if all of our view was always toward the community at large. But that's not our ultimate responsibility. It's toward the patient. But more antibiotics is not better antibiotics. Better antibiotics are better antibiotics. And so sometimes the issue is giving the doctors the courage to de-escalate when the culture says they can. Okay, great, they're on 16th generation fluoroquinolone, and it's killing it. It's so cephalosporin. This was a first generation cephalosporin. Can we de-escalate it? So that's part of it, is getting them that. It comes back to trust, right? When they see you coming, do they run? I bet they don't. I bet they don't. I bet they don't. They say, uh-oh, I need to change my orders because she's coming, not fighting you. Yes, ma'am.
I'm probably from a different ballgame because I work for the VA system, so we have a lot.
That's a different ballgame.
So we have a lot more data, and I've noticed that I have a lot of trust with my providers, but it's also really important to show them their data. So a lot of times I'll go talk to them and they'll say, oh, I don't do that. I don't prescribe Cipro for uncomplicated cystitis. And then you pull the reports. You show them, here you go. You prescribed Cipro 20 times last month. So I find that that's really helpful too, is to show them that they're doing it, not in a negative way, but just an informative way that they are.
Anybody else do that? Yeah, it's been done similar way? You have enough data, you can do that. Thanks for being here. We don't always get the VA to show up. It's awesome. It's wonderful. Thank you. It turns out the human brain is really, really bad at trending what its past practice is. We're very good at here and now and matching and all those kinds of things, but we're really bad at trending. Recent articles showed that 75% of physicians underestimated their opioid prescribing. Okay? So, is anybody surprised about that? How many of you think, okay, how many of you have gone over 75 on I-70 in the last month? Okay, here we go. That's the easy question. How many of you have gone over 75 5 or more times? How many of you 10 or more times? How many of you 20 or more times? Okay, let's get it easy. How many of you have gone over 80 10 times or more in the last... Hey, officer, come on in. And I bet you if you said you went between 10 and 20 times, I can show you probably went 32 times. Because even those kinds of behaviors, even when we admit to it, we underestimate our own frequency of use. And that's what she's talking about. You have to bring the data back to the frequency. Even if you're in a little hospital, show the doctors what their patterns are. Maybe you have to show them over a longer period of time. Show them the pattern. And if it becomes a bigger problem, you have a bigger institution, you know, that can always go to a committee meeting, their own committee meeting after you've shown them the data. Okay? You just show, here's the Pareto. How many of you do a Pareto? You know what Pareto is? So high users, low users. And you just say, well, and then you can blind them. But they know who they are. We did that with early elective delivery in Montana 5 years ago. 7 delivering doctors, and it was at their committee meeting. And we blinded the data and showed them the early elective deliverer. There were like 2, and the rest of them weren't. And the other 5 said, who are these guys doing this? Unblind the data now. And they did. It's like, Fred, Sam, what are you thinking? And they passed the whole policy of a hard stop policy at the labor and delivery deck that moment. So sometimes it can be very, very powerful to show that data. It's not necessarily enough alone. But the more local, the more the data is about the recipient, the better it gets. That's why they were asking you for not Quest, but your own antibiotic. Physician engagement. I have a talk I sometimes do called Physicians Are Human, Really? And you know, when you take busy people, I don't care if you're a CEO, a physician, a banker, a lawyer, or whatever, the attention span is short. And you got like this, you got a crack in the window to get through. And that crack, you get through it by that person on the other end believing you have something that's going to be of value. So part of it is about creating value. We talk about value-added interactions. You know, don't call me in the middle of the night. I don't tell you how many times this happened. Cross-covering and say, just wanted you to know from the ICU, Mrs. Jones Granny just get back to 2.4. Great. What was her last one? Oh, let me check. And then I'm probably soaring again for the instrument. So make your conversations value-added. And when I say don't waste physicians' time, I mean don't waste anybody's time. It's not just because they're doctors, don't waste people's time. Don't waste anybody's time. All right. What haven't we talked about, or what would you like to talk about more? We have about 10 minutes left, Michelle? Okay. Who has something that we have not touched on or they'd like to discuss more? Yes, sir. Who are you? Where are you from?
My name is Jeff Pierce. I'm from Lawrence Memorial Hospital. I'm a pharmacist. I think when we're looking at emerging pathogens from a size with being the only hospital in Lawrence, how can you affect the outpatient setting in terms of prescribing patterns and what has been successful? I know we own a lot of different primary practices, and you know we get feedback on quinolone use, but I would just kind of open up to discussion on how can you affect things that are coming into the room, into your...
Yeah. Let's go upstream a little bit, right? I talk about going upstream all the way to the patients. That is one way to do this, is you focus on the patients, whether you get them to stop demanding antibiotics. Who's worked in the outpatient sector to improve antibiotic stewardship in outpatient clinics? I'm going to go you, and then you. You two can fight over it.
So what we found, and probably what you find, is that you get this antibiotic control or stewardship program in the hospital, and then the patient goes to the primary care and they get the antibiotic they want.
Yep.
And then it's, what is that called, where you get a bad rep, the patient satisfaction rep. Your HCAHPS go down. How many have had HCAHPS go down? Right? And so you're battling one against the other. So we happened to have a champion in the urgent care setting, and we had several urgent cares, and that champion, working with Katie and myself, developed a whole antibiotic stewardship program for the outpatient based on CDC guidelines. And it went down to the individual provider level.
Good.
And they focused it on upper respiratory tract infection.
Yep.
And so they started small and they focused on one thing and they got Epic. We were fortunate enough to have Epic to track some of this stuff, and there was delayed prescribing, and they found out that actually the patients didn't go to the pharmacy and get the antibiotics when they tracked it through. So, but it was a huge effort by a champion, but it actually was very effective.
Yeah, I think that's right. You answer that?
The other thing too identified is some of the local pharmacies didn't think the date was right on delayed antibiotic prescriptions, so we also had to educate the pharmacies to make sure that we did want that prescription delayed.
Yeah. Over here, you guys are working with the outpatient docs?
Yeah, I have 3 clinics. I have 3 clinics.
Where are you again?
Southeast Kansas. So I have a hospital and 3 clinics.
Okay.
So we have med section. They all show up and we discuss it. And I do have a new practitioner that is a champion on not overuse of antibiotics. And I pointed her out in med section, and she will do a culture like if they come in with a sore throat. And then she waits for that culture to come back, and she'll do it in the ER also. And then it comes to me, and then I follow up with my doctor to show him the positive culture.
Great, great. Exactly how it should be. So, this is psychology. It's nothing more. It's not rocket science. Patients come to outpatient centers looking for antibiotics. I had a discussion, interesting, with my firefighter's son-in-law. We were talking about something. He said, well, that's what my mother does. She just goes to the doctor and tells him what she wants. So that wouldn't work very well with me. She registers, and I said, that's great. High school education and an internet. And you got an MD. So I think this HCAP thing is something, but I think it's a little bit overplayed. But it is real in the UK. Again, we have more data. The doctors who became champions on antibiotic stewardship in the outpatient saw their stars go from 4.5 to 3.5. But why? So this has been a lot of study about this in the literature. When people are going and seeking something and you don't give them that, and in fact give them nothing, they're dissatisfied, right? Give nothing. What if you spent a lot of time and money and you went and you had tickets to a baseball game in Kansas City, and when you got there, it rained out and they refused to give you any rain makeup tickets? You would have gotten nothing, right? And you would have taken home nothing. You would have got nothing. You wouldn't have got what you went for, and you got nothing in return, nothing to substitute. And so there are programs, now look, this is not easy, but there are programs looking. It starts, as I said, with education, decreasing demand, education about the risks of these antibiotics in simple, like 5th grade things that goes on posters, goes in doctors' offices, goes in clinics, goes in grocery stores. I don't care. Put them anywhere you want to put them, but to begin to decrease demand. In the doctor's offices, it can be more about the complications. Showing what some of these allergies actually look like, We don't want to scare the patients away, but let's scare them from demanding their antibiotics. Another thing is they've studied how to say no. You don't need antibiotics. I'm busy, you don't need antibiotics. Get out of here. Anybody ever watch Doc Martin? It's a wonderful British series about a surgeon with Asperger's who develops hemophobia. He's so Asperger that he doesn't realize for a long time he's actually operating on people, and that's their blood. And then one day he has this epiphany, and it is, so he can't operate anymore. So they send him off to this little Cornish fishing village where he's now the GP. And I gotta tell you, he says everything every doctor has ever wanted to say. Of course your knees and your hips hurt you. You're fat. But and that's what he would say, you don't need antibiotics, get out. But we can't do that. But yet, in some ways, we do that. Less gruff, and so then the patient's dissatisfied and angry, and they thought they were spending their $15 copay to get the antibiotics. And so what's been studied is you do need to spend some time talking about what they can do to make things better. What they can do. So what kinds of things might you suggest to parents or patients that have a URI or a pharyngitis or an uncomplicated bronchitis, the 3 big no-nos, sinusitis, the 4 big no-nos, what to give antibiotics for? Well, what might you suggest to people that might assuage their frustration and anger for not getting that RX? Yes? Shout it out. I can't get there in time.
We have an outpatient script pad.
Who are you? Where are you from? Because this is going to be good. I can tell you right now.
Jamie from Morris County Hospital, just down the road in Council Grove. And we participated in the outpatient antibiotic stewardship program through Great Plains with Nadine back here. And as part of that, we got this really nifty script pad that's a viral script pad, and on it says that you're not getting antibiotics because it's viral. And it has a place where you can write in like over-the-counter medicine for them to go to the store and get. And our patients have given us lots of awesome feedback about it. because they feel like they're still getting something from that doctor's visit. And the older ones say, well, I get to the store and there's 300 options and I can't remember which one she told me. So then they can write it on the script pad. And it's been really helpful.
I think that's brilliant. So the break, the lunch, you got to find her, Nadine in the red, and you all should have been part of this clearly. Any of you use a patient or family advisory committee, PFAC? You do. Tell us how it works.
Well, I took these prescription pads with the outpatient program on as well, and took the prescription pads to the PFAC. A couple of members were there, and they were looking at them, and one of them said, "This is exciting." She was very excited about it. She thought, how many people go to the doctor, they don't realize they have a viral infection. All they know is they're sick. You know, they're running a little bit of a fever, they feel horrible. They're trying the liquids at home, they're doing everything they know to do. So they go to the doctor, and the doctor says it's viral, and I send them home. Tell them to go to the pharmacy, pick up this stuff, that kind of thing. She said, I've had that happen to me. And when I go to the pharmacy, I can't remember whether I'm supposed to get DM or
Right, or not,
so,
whatever.
yeah. So the prescription pads she thought was really, really good, and we do use them. So I think the PFAC is important because you have to get the word out to the community.
And for something like this, you don't need a formal standing PFAC. Get a rump group. Take something like this prescription pad, or do it from scratch, and get some parents and some adults and some geriatrics. Get 6 or 8 people together in a room who want to partner with you to solve this problem. So you have to do a little screening, and get them to help you design this prescription pad, and then try it for a couple of weeks and try to get feedback on it. And if you do standard point of contact patient satisfaction surveys, okay, so add a question in about this. If you got a viral prescription, was it helpful? Whatever. Get some feedback on this. And then, you're never going to create this right the first time, so then do some iterations. We talk about small tests of change. Do some iterations. Make it better. Make it better. These work. I've heard of this before. This works. Okay, I'm going to say it to you again. Make it easy for people to do the desired thing. Make it easier for the doctors to say no. Help them say no by giving them something to give to the patient that is useful, that is real, that is not, hocus pocus. And make it easier. So we got to upstream this like we did early elective deliveries. We had to find ways to let the doctors say no to the patients. Decrease the demand, then make it easier for the doctors to say no. So I think that's really, really important. So this was a great discussion. One last comment, and then I think it just might be time for the next talk.
One of the things that happens for physicians is that they are de-incentivized to write a prescription because you get paid more.
Well, you get paid for the prescription?
No, you get paid, your ability to charge for that visit is increased because the medical decision making is higher if you write a prescription.
Yeah, I wasn't aware of that. But we still have to help do the right thing. If the right thing is making money, only making money, then we got other problems. So yeah, we have lots of screwed up misincentives in this healthcare business, and I think that we have to navigate through those while we try to improve them at another level. So I want to thank you all for your participation. I think there were some great discussions here. We covered 5 or 6, I think, useful topics. So thank you, and with that, I'm going to turn it back to you.
All right.